Just picture this. A journey from a warm, perfectly contained aquatic world to a bright, noisy, gravity-filled expanse, all in a flash. That's the extraordinary transition every newborn undertakes. It's not merely a beautiful moment, it's a physiological triumph, where in those first few hours and days, a baby undergoes some of the most profound and rapid adaptations of their entire life.
It truly is. I mean, one of nature's most intricate ballets, really, where a tiny human makes these monumental shifts across almost every bodily system, from the very first breath to independent temperature regulation, all orchestrated with just breathtaking speed and precision.
And today on the Deep Dive, we're taking a stack of expert sources from clinical assessments to detailed physiological observations to really unravel this incredible transition.
Yeah.
Our mission for you listening is to equip you with a deep understanding of what truly happens when a baby takes their first breath, what a healthy term newborn actually looks like, and how healthcare professionals meticulously ensure their well-being.
Yeah, specifically, we'll be diving into the newborn's physiological adaptation to extrauterine life, that move from inside to outside. We'll identify the normal findings in a term newborn physical examination, describe the systematic head-to-toe approach used to make sure the assessment is consistent and thorough, and review potential physical exam abnormalities that might need a closer look.
Exactly. Get ready for some genuine aha moments that reveal the marvel of new life. Okay, let's unpack this incredible journey into extrauterine life. Let's start with what is essentially a newborn's very first comprehensive report card, the APGAR score. This rapid evaluation gives critical insights right after birth. What truly makes the APGAR score such a powerful diagnostic tool in those first few minutes?
Well, the APGAR score is it's a remarkable piece of clinical ingenuity, really. It's a quick, standardized assessment performed at 1 minute and then again at 5 minutes after birth. And these two time points are absolutely crucial because the 1 minute score tells us about the baby's immediate physiological response to the birthing process itself, that initial transition.
Right, the immediate shock almost.
Exactly. Whereas the 5 minute score offers more insight into their adaptability and how well they're actually adjusting to independent life outside the womb. And if a baby is truly struggling to adapt, additional scores might be taken beyond that initial 5 minute mark, maybe at 10 minutes, 15 minutes, providing ongoing vital information to guide any needed intervention.
And it's an acronym, right? For 5 key physiological indicators. Could you walk us through what each letter stands for? And crucially, what specific observations are healthcare providers making for each one to really gauge a newborn's well-being?
That's right. Each letter provides a rapid assessment point. So first, A is for appearance. This refers to the baby's skin color. We're looking for central pinkness, meaning a pink body, chest, and face. A score of 2 is given for entirely pink. A 1 is for what we call acrocyanosis.
Ah, acrocyanosis. That's the blue hands and feet thing.
Precisely. Where the body is pink but the hands and feet appear bluish, it's actually very common in the first few minutes due to peripheral vasoconstriction as their circulation adjusts. So a 1 for that. And a 0 means the baby is entirely pale or blue.
Okay, got it. Appearance. What's P?
P is for pulse, assessing the heart rate. We listen to the apical pulse right over the apex of the heart, sometimes for 15 seconds and multiply by 4, but often for real precision. Especially initially, we listen for a full minute. A heart rate over 100 beats per minute scores a 2. Between 0 and 100 gets a 1, and an absent pulse is a 0.
Okay, pulse over 100 is good. Then G.
G stands for grimace. This assesses the baby's reflex irritability. It's their response to stimulation, like maybe a gentle suctioning of the nose or mouth, or even just a light flick on the sole of the foot. A robust cry or a sneeze scores a 2. Just a grimace or maybe a weak cry scores a 1, and absolutely no response is a 0.
Interesting. So a good, strong reaction is what you want. What about the second A?
The second A is for activity, and this reflects their muscle tone. A baby with good flexion, curled up, and active movement of all their arms and legs scores a 2. Some flexion, maybe a bit floppy but trying, scores a 1, and completely flaccid or limp tone scores a 0.
Okay, active and flexed. And the last one, R.
And finally, R is for respiration or their breathing effort. A strong, vigorous cry with regular breathing scores a solid 2. Slow, irregular breathing or maybe a weak cry scores a 1. And absolutely no breathing effort scores a 0. So each component gets scored 0, 1, or 2, and then you just sum up those 5 scores.
So once those scores are tallied, what's the interpretation? What do those total numbers really tell us about how the newborn is adapting?
Right. The total score can range from 0 to 10, and it gives a quick, actionable insight. A score of 0 to 3 signifies severe distress. That baby requires immediate intensive intervention, potentially even resuscitation. The score of 4 to 6 suggests moderate difficulty in adjusting to life outside the womb. This means the baby needs closer observation and potentially some supportive measures like maybe some blow-by oxygen or stimulation.
Okay, so lower scores mean more urgent help is needed. What about the higher range?
Exactly. Now, what's truly fascinating here is that scores of 7 to 10 represent minimal or no difficulty at all, signifying a pretty robust transition. We often see healthy transitioning newborns with scores of 8 or 9. It's actually quite rare to get a perfect 10 right at 1 minute.
Really? Why is that?
Well, precisely because almost all babies will exhibit some degree of that acrocyanosis we mentioned, the blue hands and feet immediately after birth. That typically gives them a 1 for appearance rather than a 2. And that's not usually a sign of distress. It's just a normal temporary physiological adjustment as their peripheral circulation fully kicks in. So it really underscores how the APGAR is a dynamic snapshot, you know? It guides immediate care without necessarily predicting long-term outcomes perfectly.
That detailed breakdown really clarifies how much information is packed into those quick observations. So moving from that first report card, let's talk about mastering the chill. Babies are born wet, they have a huge surface area relative to their mass, and they can lose heat incredibly quickly. Thermoregulation, just maintaining that core body temperature, has got to be a top priority right after birth. What's going on internally that makes this such a challenge, and what's a baby's remarkable secret weapon against the cold?
Yeah, you've hit on a critical vulnerability there. Newborns are incredibly susceptible to heat loss for several reasons. They have less subcutaneous fat than older kids or adults. Their large surface area to volume ratio means more skin is exposed to the environment. And their neurological mechanisms for temperature regulation are still maturing. But their remarkable secret weapon, it's an evolutionary marvel really, is something called brown fat.
Brown fat. I've heard of this. It's not like regular fat, right?
Yeah, not at all. It's a special type of adipose tissue that's pretty much unique to newborns. It's largely absent in adults, which makes it truly a baby's furnace, you could say. You'll find it primarily in strategic locations like the neck area, around the shoulders and thorax, and even deeply around the kidneys. Its primary vital function is to metabolize to burn calories non-shiveringly to produce heat.
Non-shivering, so they make heat without actually shivering.
Exactly. Think of it as the ultimate evolutionary hack, a built-in furnace that allows a tiny human to generate critical heat without expending precious energy on shivering. Shivering uses muscles and energy, but this brown fat metabolism is a more direct, metabolically efficient way to generate heat. It's utterly vital for survival in that sudden, colder, extraterrine environment. It just speaks volumes about the body's priority, maintaining core temperature at all costs.
That's incredible specialized internal heating system. But I imagine some babies might be at a distinct disadvantage with this, especially if their brown fat reserves aren't fully developed.
Oh, absolutely. Premature babies, for instance, often lack sufficient brown fat because it develops mostly later in gestation, like in the last trimester. This, combined with their underdeveloped skin, which is thinner and poorer muscle tone, puts them at a much, much higher risk for cold stress. But even a full-term baby, if they get too cold for too long, will rapidly burn through their brown fat reserves.
And that's not good, I'm guessing.
No, it isn't sustainable. It depletes their energy stores, their glucose, which can then lead to their temperature dropping even further, causing hypothermia. And this can trigger a whole cascade of serious issues, increased oxygen consumption, because metabolism ramps up, potential respiratory distress, and hypoglycemia, low blood sugar, as their body struggles to generate heat and maintain metabolic balance.
It's at this point that the newborn's immediate environment and the care they receive reveal some truly extraordinary adaptations and crucial preventative measures. What I find particularly fascinating about this stage is how babies lose heat in different ways and what targeted actions we take to prevent it. Can you break down the 4 main mechanisms of heat loss for us?
Certainly. Understanding these specific mechanisms is really foundational to effective newborn thermoregulation. It guides everything we do in those first hours. First, we have evaporation. This is heat loss through the conversion of water on the baby's skin surface into vapor. The most obvious example is right at birth, when a baby is born wet with amniotic fluid, or later during and after a bath.
Okay, so wet skin equals heat loss.
Yeah.
How do we stop that?
The prevention is straightforward but absolutely critical. Immediately and thoroughly drying the baby, wrapping them snugly in a warm blanket or swaddling them, and placing a hat on their head. A lot of heat is lost through the head. This is precisely why delayed bathing is now standard practice in most healthy newborns. We typically wait until the baby is at least 8 hours old, sometimes even 24 hours.
Why the delay?
It just gives them ample time to stabilize their temperature naturally without the added stress of evaporative heat loss from bathing. It lets that vernix coating do its job too. The only real exceptions are for specific medical reasons, like if the mother is positive for HIV or perhaps hepatitis B. In those cases, earlier bathing might be needed for the baby's safety to remove potentially infectious material.
It truly is remarkable how such simple actions, drying, hat, delaying a bath, can have such profound impact on a newborn's well-being. But that's just one avenue of heat loss. What are the other crucial mechanisms we need to understand?
Right. Next is conduction. This is heat loss through direct contact with a colder surface. Imagine a baby being placed on a cold examination table, or touched by cold hands, or even a cold stethoscope. The baby's body heat transfers directly to that colder object.
Ouch. Yeah, I can see that. So warming things up first.
Exactly. Healthcare providers are meticulous about warming their hands, warming stethoscopes under their arm or with a warmer, and placing warm blankets or towels on any surfaces like scales or exam tables that will come into direct contact with the baby. It's a simple yet profound aspect of empathetic care, really, ensuring the baby's comfort and metabolic stability.
Okay, evaporation and conduction. What else?
Then there's convection. This is heat loss to cooler ambient air currents flowing over the baby's body. Think about a fan blowing in the room, or open windows creating a draft, or even administering unheated oxygen directly to the baby. That moving air whisks heat away. Prevention involves eliminating these air currents, avoiding drafts, closing windows, making sure the baby's bassinet isn't near a vent, and critically, ensuring any administered oxygen is warmed and humidified.
Makes sense. Avoid the breeze. And the last one.
Finally, there's radiation. This is heat loss to colder solid surfaces nearby, even without direct physical contact. Think of placing a baby in a crib right next to a cold window, especially in winter. The baby's body radiates heat outwards toward those colder surfaces, even if they aren't touching. To prevent this, the baby should be positioned away from cold outside walls or windows. Care environments often use radiant warmers overhead, which provide a warm environment without direct contact, counteracting this radiative loss.
So every single aspect of the immediate environment and the care needs to be carefully managed. Given these challenges, what are the most critical warning signs and risk factors for cold stress that healthcare providers and parents absolutely need to be aware of?
Well, the primary risk factor, as we touched on, is prematurity. They just don't have enough brown fat, their size is small, their systems are immature, but also any condition that causes a term baby to rapidly burn through their brown fat reserves, like a difficult birth, an infection, or maybe respiratory distress, also puts them at high risk. As for signs and symptoms of cold stress, they can be subtle at first, but escalate quickly.
What should we look for?
You'd typically observe lethargy. The baby might be less active, less responsive, maybe harder to rouse for feeding. Their skin will feel cool to the touch, especially the extremities, but eventually the core too. And their core temperature would be below 97.7 degrees or 36.5 degrees C, even if it's just slightly below that mark. That's a key indicator. Other crucial signs include hypoglycemia, low blood sugar, which develops rapidly as the body burns through glucose trying to generate heat.
Okay, so lethargy, cool skin, low temp, low sugar. Anything else?
Yes, you might also see signs of respiratory distress, like nasal flaring or grunting, as the increased metabolism demands more oxygen and the body struggles. And a weak or ineffective suck when feeding is another red flag. They just don't have the energy. This is why checking temperature regularly is paramount in those first hours and days, and swift action is needed if it starts to drop.
These signs sound like they can quickly spiral into a pretty serious situation. What are the practical, immediate, and ongoing interventions to prevent and treat cold stress that every care provider and parent should know?
Immediately after birth, assuming the baby is stable, skin-to-skin contact with the parent is incredibly effective. We often call it kangaroo care. It transfers warmth directly from the parent to the baby, helps stabilize vital signs like heart rate and breathing, and promotes bonding. It's really powerful. Thorough drying, swaddling the baby snugly in warm blankets, and putting that hat on their head are also immediate universal actions right in the delivery room.
And for ongoing care, if the baby does get cold.
For ongoing care, the judicious use of radiant warmers is common if a baby is cold. These allow for controlled, slow rewarming to a target of around 97.8 degrees hour or 36.6 degrees C or higher. You have to rewarm slowly to avoid other problems. Warming any intravenous fluids if they're being administered is also important. And dressing the baby appropriately, the general rule of thumb is typically one extra layer than what an adult is comfortably wearing in the same environment. And as we discussed, checking glucose levels if cold stress is suspected is a key diagnostic and therapeutic step. If levels are low, feeding is the first line, followed potentially by glucose gel if needed. The emphasis is always, always on proactive prevention and rapid response.
That's a truly comprehensive approach to keeping a newborn cozy and safe. Now let's talk about perhaps the most dramatic adaptation of all, that first breath, and the incredible, almost instantaneous symphony of lungs and circulation that comes with it. What precisely triggers this vital moment, and what does it set in motion?
The trigger is quite stark and absolute, really. Once the umbilical cord is clamped and cut, the placenta, which has been the baby's lifeline for oxygen and waste removal, is suddenly offline. It's no longer providing those vital functions. This physiological shift causes a rapid drop in the baby's blood oxygen levels and a rise in carbon dioxide. This change signals the baby's central nervous system, specifically the respiratory center in the brainstem, that it's time for the lungs to take over, like right now. This initiation of pulmonary respiration triggers a whole cascade of mechanical, thermal, the cooler air, chemical, the O2-CO2 shift, and sensory stimuli, like being handled and dried, all converging to initiate that crucial first breath. It's typically a deep gasp followed by a vigorous cry.
Wow. Now, I've heard that babies born vaginally have a bit of an advantage here over those born via C-section when it comes to clearing their lungs. Is that true? And if so, what's the physiological mechanism behind it?
It is indeed true, and it really highlights the genius of the natural birth process. As a baby passes through the narrow birth canal during a vaginal birth, their chest is compressed quite significantly. This compression acts like a natural squeeze, physically pushing out a substantial amount of the amniotic fluid that has filled their lungs while in utero. It gives them a head start on clearing those airways.
So C-section babies miss that squeeze.
Exactly. Babies born via C-section miss this crucial thoracic squeeze. Consequently, they may have more amniotic fluid remaining in their lungs right after birth. This can lead to transient crackles when we listen to their lungs. It sounds wet. But this can actually be a normal finding for the first 1 to 2 hours of life. That fluid is gradually absorbed through their pulmonary circulation and lymphatic system within the first couple of hours. So while it sounds a bit concerning initially, it often resolves spontaneously pretty quickly.
And crying. It plays a huge functional role here, doesn't it? Beyond just being a sign they're awake or expressing discomfort.
Oh, absolutely. Crying is incredibly important. It performs a vital mechanical function for the lungs. It's not just an expression. The vigorous muscular effort of crying creates significant positive pressure within the lungs. This pressure is essential. It helps to pop open and expand the tiny air sacs, the alveoli, which were collapsed and fluid-filled before birth, and critically, it helps to keep them open for effective breathing and gas exchange.
So a weak cry could be a problem.
Yes. Conversely, a weak or absent cry can actually be a warning sign of respiratory problems. It might indicate the baby isn't generating that crucial positive pressure needed for proper lung expansion and fluid clearance. It suggests they might need some help.
So when we're assessing a newborn's breathing, what are the normal respiratory rates we're looking for, and what specific patterns or warning signs should we be really watching out for?
A normal respiratory rate for a newborn is typically between 30 and 60 breaths per minute, but it can be irregular. That's why it's absolutely essential to count this for a full minute. You can do this by visualizing the chest movement, gently auscultating with a stethoscope over the chest, or even palpating the chest wall lightly. That full minute count is vital because newborns often exhibit something called periodic breathing. Periodic breathing, what's that? It consists of short pauses in breathing, typically lasting less than 15 seconds, often followed by a burst of rapid breathing. These brief pauses are considered a normal, immature pattern in newborns. It can look a bit alarming, but it's okay. However, a pause in breathing that lasts longer than 15 to 20 seconds is defined as apnea. That is not normal and requires immediate evaluation.
Okay, so short pauses are okay, long pauses are not. What other warning signs for breathing?
Another critical sign of respiratory distress to watch for is nasal flaring. Remember, babies are obligate nose breathers. They primarily breathe through their noses. So if you see their nostrils flaring out with each breath, it indicates they are actively working hard to get air in, and that's a significant red flag requiring prompt attention. Other signs would be grunting sounds with exhalation, retractions where you see the skin sucking in between the ribs or under the breastbone with each breath, or tachypnea, which is a respiratory rate persistently over 60 breaths per minute when they're resting.
It's just astounding how many transformations are happening all at once. The circulatory system also undergoes this massive, almost instantaneous reorganization.
Mm.
What were those specific fetal shunts that bypass the lungs, and how do they dynamically change and close after birth? It seems like biological magic.
It really does seem like magic, doesn't it? The circulatory system's transformation is arguably the most dramatic. In utero, the baby's circulatory system largely bypasses the lungs because, well, the placenta is handling all the oxygenation and waste removal. This bypass is managed by three key fetal shunts. These are specialized blood vessels and an opening within the heart itself. First, there's the ductus venosus. This acts as a crucial shortcut, diverting oxygenated blood coming from the umbilical vein directly past the liver, which isn't fully active yet, straight into the inferior vena cava and then to the baby's heart. An elegant bypass.
Okay, bypasses the liver.
Yeah.
What else?
Second is the foramen ovale. This is an actual opening, like a flap valve, between the right and left atria of the heart. It allows a large portion of that oxygenated blood coming into the right atrium to flow directly across to the left atrium, bypassing the pulmonary circulation, the trip to the lungs altogether. And third, there's the ductus arteriosus. This is a shunt, a blood vessel that connects the pulmonary artery, which normally leads to the lungs, directly to the aorta, which leads to the rest of the body. This effectively shunts blood away from the high-resistance fetal lungs and out to the systemic circulation.
So 3 bypasses. What happens at birth? How do they close?
Right. Post-birth, as the baby takes those first breaths and the lungs inflate with air, the resistance in the pulmonary blood vessels dramatically drops. Blood starts flowing easily to the lungs now. This, combined with the clamping of the cord-altering pressures, causes blood flow patterns to completely change. These shunts typically begin to close functionally within the first few hours to 24 hours of life. The increased oxygen levels in the blood and the altered pressure gradients in the heart and the great vessels trigger their functional closure. Eventually, over days or weeks, they close anatomically, basically turning into ligaments. The foramen ovale flap usually seals shut.
This raises an important question then. If these shunts are in the process of closing, is that why we sometimes hear heart murmurs in newborns? And how do we differentiate between, a benign transitional murmur and something more concerning?
Precisely. That's exactly why. Hearing a heart murmur in the first 24, even 48 hours of life is not uncommon at all. And it's often due to these shunts, particularly the ductus arteriosus, still being in the process of functionally closing. As blood flows through these partially closed, narrow structures, it can create turbulent sounds, sort of like water rushing through a narrow pipe, and we hear that as a murmur. The vast majority of these are benign transitional murmurs and usually resolve on their own as the closure completes over the first few days.
It's usually nothing to worry about.
Usually not. However, a persistent murmur, one that's very loud, or a murmur associated with other signs of distress, like cyanosis, bluish skin, poor feeding, or difficulty breathing, would definitely warrant further investigation by a pediatric cardiologist to rule out a congenital heart defect. And on a related note, the umbilical cord itself gives us clues about the circulatory system. We always check it immediately after birth. It should normally have 3 vessels, 2 arteries, and 1 vein. AVA, artery, vein, artery.
What if it only have 2?
A 2-vessel cord, usually missing 1 artery, can sometimes be associated with underlying cardiac or renal kidney issues. That doesn't always mean there's a problem, but it warrants a closer look and maybe some further screening, like an ultrasound. And interestingly, in critical situations, like with a very premature or sick infant, those umbilical vessels, particularly the vein, can actually be accessed as an IV site for rapid administration of medications or fluids right after birth. It's called an umbilical venous catheter, or UVC.
Wow, okay. What about normal heart rates and blood pressure for a newborn? Are these routinely assessed in the same way they would be for an adult or older child?
A normal heart rate for a newborn is significantly faster than an adult's, typically ranging from 110 to 160 beats per minute when they're awake and calm. It can dip lower when they're in deep sleep, maybe down to 80 or 90, or go higher if they're crying, maybe up to 180. We always auscultate the apical pulse, listening right at the heart's apex for a full minute to get an accurate average reading, because the rate can fluctuate quite a bit. As for blood pressure, a typical range is around 60-80 mmHg systolic, over 40-50 mmHg diastolic at birth. However, blood pressure is generally not routinely assessed on a normal, healthy-term newborn.
Why not?
Well, partly because it's technically challenging to get an accurate reading with the right cuff size in a wiggly baby. More importantly, other indicators like heart rate, skin color, capillary refill time, and overall perfusion are often more immediate and reliable indicators of circulatory stability in a healthy newborn. We'd primarily check blood pressure if the baby is premature, very ill, or if there were complications during delivery that suggest potential cardiovascular compromise. Then it becomes a much more important vital sign to track.
Now that we've covered the profound shifts in breathing and circulation, let's turn our attention to the gastrointestinal and genitourinary milestones. What does that first day of feeding and output realistically look like for a newborn? And what should parents expect? Seems like a whole different world there, too.
Oh, it is. When it comes to the gastrointestinal system, parents are often really surprised by just how tiny a newborn's stomach actually is. On the first day, it's incredibly small, only holding about 5 to 7 milliliters. That's roughly the size of a cherry or a large marble. This capacity gradually increases over the first week or so.
Wow, 5-7 milliliter, that's tiny.
It is, and food moves quickly through their system too. The stomach emptying time is just about 2 to 4 hours, sometimes even faster for breast milk, which is digested more easily than formula. This rapid emptying explains precisely why newborns, especially breastfed babies, need to feed so frequently, often every 1.5 to 3 hours. They digest quickly and just need small, frequent refills.
So what does this all mean for tracking a baby's output, particularly their first stool? I know it's called meconium, and it looks pretty distinct.
That's right. The baby's first stool, meconium, is quite unique. It's typically dark, greenish, black or black, very tarry, thick, sticky, and importantly, it's odorless. It's composed of stuff the baby swallowed in uteroamniotic fluid, intestinal epithelial cells, lanugo, that fine hair, bile, and water that accumulated during fetal life. It's absolutely crucial that a baby passes at least one meconium stool within the first 24 hours of life. Sometimes it can take up to 48 hours, but delayed passage beyond that can sometimes signal an intestinal obstruction or other issues like Hirschsprung's disease or cystic fibrosis, so we watch for it closely.
And after the meconium, what happens to the stools?
After those initial 1 or 2 meconium stools, the stool pattern transitions over the next few days to what are called transitional stools. These are usually thinner, looser, and greenish-brown or greenish-yellow. Then the pattern really diverges based on feeding. Breastfed babies often have distinct yellow, seedy, like mustard with seeds, often quite liquidy or pasty stools. They might stool with every feeding. Formula-fed babies, on the other hand, typically have more formed, paler yellow to light brownish stools, maybe a bit more peanut butter consistency, and they might stool less frequently. Educating parents on these normal changes is vital so they know what to expect and can recognize healthy output patterns. We typically look for babies to have at least 1 wet diaper and 1 soiled diaper per day of life for the first few days. So 2 wet, 2 dirty on day 2, etc. Eventually increasing to about 6 to 8 wet diapers and maybe 3 to 4 soiled diapers per day by day 5 or so.
Okay, that's helpful. And on the genitourinary side, the peeing side, what are the key milestones parents should anticipate for their newborn?
For genitourinary development, the main thing is that a newborn should have at least 1 void or urination within the first 24 hours of life. It's actually not uncommon for this to take up to 20 hours, or even close to 24, as their kidneys are just starting to function in this new environment, and they might not have taken in much fluid yet, especially if breastfeeding is just getting established. The first few voids might look a bit cloudy, or even have a slightly orange-pinkish stain in the diaper. This is often due to uric acid crystals concentrating in the urine, and is usually a normal finding in the first couple of days, not blood. We call it brick dust urine.
Okay, so 1 pee in 24 hours is the goal. Anything else specific to female babies?
Yes, for female babies, you might observe a phenomenon called pseudomenstruation. Due to the abrupt withdrawal of maternal estrogen hormones that cross the placenta during pregnancy, female newborns may have a small amount of whitish vaginal discharge, sometimes even tinged with a little bit of blood. This is a completely normal and temporary finding, usually lasting only a few days. It's important for parents to know not to be alarmed by it. It's just another clear example of how maternal physiology directly impacts the newborn's early days.
We've delved into the unseen, intricate physiological transformations happening inside the newborn. Now let's embark on the next crucial step of this grand debut, the meticulous, hands-on exploration of the newborn's physical self, a head-to-toe journey that brings these internal marvels to light. I imagine maintaining that neutral thermal environment we talked about is still absolutely key during the exam itself.
Oh, absolutely. Throughout the entire examination, promoting a neutral thermal environment remains a top priority. We want to prevent cold stress and allow for an accurate, undisturbed assessment. So, Keep the baby warm, expose only the part you're examining. But even before you touch the baby for the physical assessment, identification and safety are absolutely foundational. Can't stress this enough. The baby should have 2 identification bands on them, usually one on the wrist and one on the ankle, with numbers that perfectly match a band worn by the mother or primary support person. Additionally, many hospitals use a security tag, often on the ankle or umbilical cord clamp, which alarms if the baby is taken near an exit. All these bands must have clearly visible, matching numbers and information.
And checking them is crucial.
Critically important. It's vital to re-identify the baby every single time they are brought back to the room, say, from the nursery, or after a procedure like a hearing screen or circumcision, by actively checking the band numbers with the parent. It prevents horrific mix-ups.
That's a rigorous safety protocol, and rightly so. And what about that little bulb syringe I often see clipped to the crib? What's the important safety rule associated with using that, if needed?
Right, that's a vital piece of safety equipment, particularly in the immediate post-delivery period or if the baby spits up. A bulb syringe should always be readily available in the crib or bassinet. If it's ever needed to clear the baby's airways, the important physiological rule and mnemonic to remember is mouth before nose, M before N in the alphabet.
Mouth before nose. Why that order?
It's a critical safety measure. You suction the mouth first to clear out any secretions or milk that might be pooled there. If you suction the nose first, the stimulation can cause the baby to gasp, and if there's stuff in the mouth, they could aspirate it into their lungs. And remember, babies are obligate nose breathers, so clearing the nose is important too, but only after the mouth is clear.
Got it. Mouth first, then nose. Okay, once safety is assured, what's the very first overarching step in assessing a newborn before you start the detailed examination?
The initial step is always a general survey. This is an overall visual assessment, something you observe as soon as you see the baby, even before you lay hands on them or pick up your stethoscope. We're observing their overall muscle tone and posture. Ideally, they should be flexed and active, not limp. We check their general skin color. Are they pink, pale, jaundiced, cyanotic? We look at their respiratory pattern. Is it easy, unlabored, or are they showing signs of distress? And we assess their overall level of alertness. Are they awake and active, quietly alert, drowsy, or lethargic? This general survey provides an invaluable initial impression of their overall well-being and helps guide the urgency and focus of the subsequent detailed assessment.
Okay, let's unpack this now. What's the most effective and systematic order for conducting a truly thorough newborn exam, ensuring nothing gets missed in the process?
Right. For efficiency, accuracy, and importantly, to minimize distress to the newborn, the most effective approach is generally accepted to be: start with the quiet things first. This means always begin with vital signs, temperature, heart rate, and respiratory rate before you start poking and prodding and potentially upsetting the baby. This allows for accurate baseline readings when the baby is hopefully calm and resting.
Makes sense. Listen first.
Exactly. While you're listening to the apical heart rate for that full minute, you can simultaneously listen to the quality of the heart sounds, any murmurs. And while you're watching or listening to the respiratory rate for a full minute, you can also listen to the lung sounds in all fields. Are they clear? Are there crackles, wheezes? Get the auscultation done while they're quiet. After the vital signs and auscultation, you then proceed systematically with a comprehensive head-to-toe approach. This ensures every body system and structure is assessed methodically, reducing the chance that something is inadvertently missed. This systematic method also ensures consistency between different caregivers performing the exam and promotes completeness of the assessment documentation.
And as part of that initial assessment, what are the normal measurements we're looking for in a healthy term newborn, and what can abnormal measurements potentially signify?
These measurements provide crucial baseline data. For a healthy term newborn, the typical normal findings are weight, generally between 2,500 and 4,000 grams, which is roughly 5 pounds 8 ounces to 8 pounds 13 ounces. Monitoring for appropriate weight loss is key in the first few days. Up to 10% loss from birth weight is generally considered acceptable, mostly due to fluid shifts and meconium passage. They should then start gaining and ideally be back to birth weight by about 10 days to 2 weeks. Length. Usually 45 to 55 centimeters, which is about 18 to 22 inches, measured from head to heel with the leg extended, head circumference. Typically 32 to 36.8 centimeters, roughly 12.6 to 14.5 inches, measured around the largest part of the head, over the eyebrows and occiput. This measurement is really important for tracking brain growth. It's typically about 2 centimeters larger than the chest circumference.
And what if the head circumference is off?
Significant abnormalities here are red flags. If it's too small, microcephaly, it might suggest inadequate brain development, perhaps due to genetic disorders, prenatal infections like Zika or CMV, or exposure to toxins. If it's too large macrocephaly, it could indicate hydrocephalus, which is a buildup of cerebrospinal fluid in the brain requiring urgent attention, or it could be familial or related to other syndromes. Chest circumference, usually 30 to 33 centimeters, about 12 to 13 inches, measured at the nipple line.
Okay. And you mentioned term newborn. How is gestational age classified?
Right, it's important to classify by gestational age interpretation. A term newborn is one delivered between 37 weeks 0 days and 41 weeks 6 days of gestation. Preterm is less than 37 completed weeks, and postterm is defined as greater than 42 weeks 0 days gestation.
And how does weight relate to that gestational age?
Good question. We also assess weight for gestational age using standardized growth charts. This helps us understand if the baby's growth in utero was appropriate for how long they were inside. Appropriate for gestational age, AGA, means the baby's weight falls between the 10th and 90th percentile for their specific gestational age. This indicates generally healthy fetal growth. Small for gestational age, SGA, means the weight is less than the 10th percentile. This could be due to constitutional factors, just a genetically small baby, or due to things like placental insufficiency, maternal hypertension, smoking, or infections. SGA babies are at higher risk for hypoglycemia and thermoregulation problems, and large for gestational age LGA means the weight is greater than the 90th percentile. This is often seen in babies of diabetic mothers due to excess glucose exposure, but can also be genetic. LGA babies are at risk for birth injuries, like shoulder dystocia, hypoglycemia after birth due to high insulin levels, and sometimes respiratory distress. So these classifications, term, preterm, postterm, and AGUS GOLGA, really help us frame the assessment and anticipate potential risks or needs for that specific baby.
So many intricate details that collectively paint a picture of overall health and potential vulnerabilities. Let's move into the physical assessment itself now, starting with posture and the skin. These can provide a wealth of first impressions. What's a normal posture for a healthy term newborn? And what does that posture tell us?
A healthy term newborn typically assumes a general flexed posture. Think curled up, arms and legs drawn in towards the body, similar to how they were positioned snugly in utero. Hips and knees are flexed, arms are often flexed at the elbows. They should also exhibit good active muscle tone, meaning there's some resistance if you gently try to extend their limbs, and they tend to recoil back to that flexed position. And they should be able to move all their extremities symmetrically and spontaneously. This flexed posture and good tone are actually key components assessed in the neuromuscular section of the Ballard score, which is a tool often used right after birth to more precisely estimate gestational age, especially if dates are uncertain. A more flexed posture, greater resistance to extension, and rapid recoil generally indicate a more mature, full-term baby with well-developed muscle tone. It's a reassuring sign of neurological health. A very limp or extended posture might suggest prematurity or neurological issues.
Okay, flexed and active is good. Now, the skin is often the first thing parents and providers notice, and you said it can be a canvas of clues. What are some of the fascinating normal skin findings that parents might initially be concerned about, but are actually benign and transient?
Oh, the skin truly is a remarkable indicator of transition and health. And yes, what's fascinating here is that some findings, though they might look a bit alarming to new parents, are perfectly normal parts of adjusting to life outside the womb. One we already mentioned is acrocyanosis. This is that bluish discoloration of the hands and feet while the rest of the body is pink. It's normal for the first 24 to 48 hours, sometimes longer if they get cold. It's just a reflection of their still maturing peripheral circulation as blood flow gets prioritized to the vital organs first. It's benign and resolves as circulation improves.
Okay, blue hands, feet are usually okay initially. What about yellow skin? Jaundice.
Right, jaundice. A slight yellowing of the skin and/or the whites of the eyes, sclera, known as physiological jaundice, is very common. It typically appears after the first 24 hours, usually peaks around day 3 to 5, and then gradually fades over a week or two. This happens because the newborn's liver is still immature and less efficient at processing bilirubin, which is a byproduct of the normal breakdown of red blood cells. And babies have extra red blood cells at birth that need breaking down. We monitor transcutaneous bilirubin, TCB, levels non-invasively, often with a device placed gently on the forehead or chest, to screen for levels that might be rising too high or too fast. Jaundice appearing within the first 24 hours, or rising very rapidly or lasting too long, is not physiological and needs investigation for underlying causes.
Good distinction. What else might we see on the skin?
We also check skin turgor, gently pinching the skin, usually on the abdomen or thigh, to see how quickly it springs back. Good turgor indicates adequate hydration. If it stays tented, that suggests dehydration. The skin texture itself can vary. Full-term babies, especially those who are slightly post-term, may show some dry, cracking, or peeling skin, particularly on the wrists, ankles, and feet. This is normal as the outer layer shed. Premature babies, conversely, often have much smoother, thinner, almost translucent skin with visible veins. Then there's vernix caseosa. This is that thick, white, cheesy, waxy substance that coats the baby's skin in utero. It acts as a protective barrier against the amniotic fluid.
Should be washed off.
Current practice is often to leave it on or gently wipe off the excess rather than vigorously washing it all off immediately after birth. It's thought to have moisturizing and possibly antimicrobial properties. The amount varies. Preterm babies tend to have more vernix, while full-term or post-term babies often have less, maybe just in the creases, like armpits, groin. We always wear gloves when assessing the skin, especially before the first bath, due to vernix and other bodily fluids. Lanugo is another common finding. This is that fine, downy hair often found on the baby's back, shoulders, forehead, and ears. Again, it's more prominent in preterm infants and tends to decrease closer to term, often disappearing by birth or shortly after. Amelia are tiny white dots, like miniature whiteheads, commonly seen on the nose, chin, and forehead. They're caused by blocked sebaceous glands, are totally benign, and resolve on their own within a few weeks without any treatment. Parents should be advised not to squeeze them.
Okay, lots of normal variations there. What about birthmarks? I know those can definitely be a source of worry or questions for first-time parents. How can we differentiate between normal variations and those that might warrant a closer look?
Absolutely. Birthmarks are very common, and the vast majority are completely harmless normal variations. Mongolian spots, now more appropriately termed congenital dermal melanocytosis, appear as flat, bluish-gray or grayish-brown patches, often resembling a bruise. They're usually found on the sacral area, buttocks, or lower back, but can occasionally appear elsewhere, like shoulders or legs. They are much more common in babies with darker skin tones, Asian, Hispanic, African, indigenous backgrounds. They are simply collections of pigment cells deep in the skin, are completely benign, and typically fade gradually over the first few years of life, though some may persist faintly. It's crucial to document these accurately at birth to avoid any misinterpretation as bruising later on.
Good point about documentation. What other common ones?
Erythema toxicum, often called the newborn rash or flea bite rash, is very common. It typically appears within the first few days of life and looks like red, splotchy patches with small, central yellowish or white papules or pustules, little bumps or pimple-like spots. It can appear anywhere on the body except the palms and soles, and the spots tend to come and go, moving around. It looks dramatic, but it's a normal, temporary inflammatory response and resolves spontaneously within a week or two without treatment. Stork bites, technically called salmon patches or nevus simplex, are small, flat, pale pink or reddish patches. They're often found on the nape of the neck, stork bite, between the eyebrows, angel kiss, or on the eyelids. These are caused by clusters of dilated capillaries near the skin surface. They're very common, completely benign, and usually fade significantly within the first year or two, although those on the nape of the neck sometimes persist faintly into adulthood.
Okay, those sound very common. What about brown spots?
Right. Cafe au lait spots are flat, uniformly pigmented patches that are light brown, like coffee with milk, hence the name. A few small ones, typically defined as less than 6 spots and smaller than 0.5 centimeters in diameter in infancy, are generally considered normal and occur in many children. However, having multiple, usually defined as 6 or more, larger cafe au lait spots can sometimes be associated with certain genetic conditions, most notably neurofibromatosis type 1, NF1. So while 1 or 2 small ones are usually fine, the number and size are important factors to note and monitor. It's absolutely vital to educate parents about all these normal skin findings. Reassuring them that the blotchy rash or the blue spot is normal prevents unnecessary anxiety. Clear explanations and documentation are key.
Definitely. Okay, let's move up to the head and face. Here's where the newborn's anatomy reveals some truly extraordinary adaptations, isn't it? Those soft spots, the fondales, what are they all about and why are they so crucial?
They absolutely are extraordinary adaptations. The soft spots are called fontanelles, or fontanelles. They're basically fibrous membranes covering the gaps or openings where the major skull bones haven't yet fused together. These are absolutely crucial for 2 main reasons. Firstly, they allow the bony plates of the skull to overlap and compress slightly during passage through the birth canal. This is called molding, and it helps the large head fit through. Secondly, and just as importantly, they accommodate the incredibly rapid brain growth that occurs during infancy, especially the first year of life. The brain basically doubles in size in the first year. There are 2 main ones we assess. The anterior fontanelle, which is the larger diamond-shaped one located at the top of the head towards the front, it typically closes sometime between 9 months and 18 months of age, sometimes a bit later. The posterior fontanelle, which is smaller and triangle-shaped, is located at the back of the head. It usually closes much earlier, often by 2 to 4 months of age. Both should normally feel soft and flat when the baby is calm and upright. You might even feel a slight pulsation, which is normal.
So soft and flat is normal. What would be considered an abnormal finding for the fontanelles, and what might that indicate?
Abnormal findings can be very significant clinical signs. A bulging or tense fontanelle, especially when the baby is calm and hasn't just been crying vigorously, can indicate increased intracranial pressure. This is a serious sign and could be due to conditions like hydrocephalus, excess fluid in the brain, meningitis, infection, or bleeding inside the head. It needs immediate medical evaluation. Conversely, a significantly depressed or sunken fontanelle can be a sign of moderate to severe dehydration. This also requires prompt attention and fluid management. We also assess the sutures, which are the lines or fibrous joints where the skull bones meet. In a newborn, these sutures might feel slightly separated, or they might feel ridged if the bones overlap during birth. This overlapping, as we mentioned, allows the head to mold to fit through the birth canal, sometimes creating that temporary elongated or cone head appearance, especially after a long labor or vacuum delivery.
And that molding is normal.
Yes, molding is a normal adaptive mechanism, and that cone shape typically resolves within 2 to 3 days as the bones shift back into their normal positions and the head rounds out.
That's a great distinction. Now, I've also heard of different types of head swellings that can occur right after birth that aren't just molding. Can you help us distinguish between potential abnormalities like a caput succedaneum and a cephalohematoma? This could be really confusing, I think, especially for parents seeing swelling on their baby's head.
This is a really important distinction to make, and yes, it often causes understandable concern for parents. Both are related to birth trauma or pressure, but they're different. A caput succedaneum, often just called caput, is a diffuse swelling or edema of the soft tissues of the scalp. It feels soft, boggy, and sometimes spongy. You might see some bruising associated with it. The key characteristic here is that this swelling crosses the suture lines. It's not confined to the boundaries of one skull bone, it can spread across them. It's often caused by prolonged pressure of the head against the cervix during labor or by vacuum extraction. This swelling is usually present at birth and typically resolves fairly quickly, within a few days as the fluid is reabsorbed.
Okay, so caput is soft, crosses suture lines, resolves quickly. What about the other one?
The other one is a cephalohematoma. This is the collection of blood under the scalp, specifically between the skull bone and its tough outer covering layer, the periosteum. Because it's bleeding under the periosteum of a specific bone, the crucial difference here is that a cephalohematoma does not cross the suture lines. It's confined to the surface of a single cranial bone, often the parietal bone on one side. It might not be apparent immediately at birth, but can develop over the first day or two. It feels firmer than a caput, more well-defined at the edges. You can often feel the edge of the bone around it. This is also often related to birth trauma, like pressure from forceps or just a difficult passage. Because it's a collection of actual blood, it takes significantly longer to resolve than a caput, often several weeks or even months, as the blood is slowly broken down and reabsorbed by the body. Cephalohematomas also slightly increase the risk for jaundice as that trapped blood breaks down. So educating parents clearly on these differences, caput crosses lines, cephalohematoma doesn't. Caput resolves fast, cephalohematoma takes weeks along with their causes and expected resolution, is absolutely vital for reassurance and managing expectations.
That's a super clear explanation, thank you. Moving down to the face now. What are we meticulously looking for in a newborn's facial assessment, beyond just overall appearance or cuteness?
Beyond the cuteness factor. On the face, we primarily look for overall symmetry of the facial features, especially during movement like crying. We're checking if both sides of the face move equally. Any asymmetry could suggest facial nerve palsy, often related to pressure during birth, like from forceps, which usually resolves but needs monitoring. We check the position and formation of the ears. As a general guideline, the top of the ear, the pinna, should ideally align horizontally with the outer corner of the eye, the undercanthus. Ears that are positioned significantly lower than this alignment are described as low-set ears. This finding, along with unusually shaped ears, can sometimes be associated with certain chromosomal abnormalities, like Down syndrome or Turner syndrome, or other congenital syndromes. So it's an important observation that would warrant further evaluation and potentially genetic screening.
Okay, symmetry in ear position. What about inside the mouth?
Inside the mouth, we assess several things. We check the sucking reflex by gently placing a clean, gloved finger into the baby's mouth, touching the palate. A healthy term newborn should immediately begin to suck vigorously and rhythmically around the finger. This confirms the reflex is intact, which is crucial for feeding. While the finger is in there, we simultaneously palpate the roof of the mouth, both the hard palate front and the soft palate back, to ensure the palate is intact and there is no opening, or cleft palate. A cleft palate can range from a small notch in the soft palate to a complete opening extending through the hard palate, and it can significantly impact feeding and require surgical repair later. We also visually inspect the tongue and the floor of the mouth. We look for a possible tongue tie, ankyloglossia, where the frenulum, the thin membrane connecting the underside of the tongue to the floor of the mouth, is unusually short or tight, restricting the tongue's movement. A significant tongue tie can sometimes interfere with effective latching during breastfeeding and may require a simple clipping procedure for phrenotomy later if it causes feeding problems. We also inspect the lips carefully for any splits or gaps, which would indicate a cleft lip. This can occur alone or in conjunction with a cleft palate. And finally, we look at the nose. We check for patency that the nostrils are open by briefly occluding one nostril at a time while observing breathing through the other if the baby is calm. And crucially, as we discussed earlier in respiratory assessment, we observe for any nasal flaring, which is that widening of the nostrils during inhalation. Since babies are obligate nose breathers, any nasal flaring is a significant sign of respiratory distress, indicating they're working hard to get enough air.
Now let's explore the trunk, genitalia, and extremities. These areas speak to core function, movement, and really critical neurological development, right? What do we assess in the neck and chest, and what are the normal findings there?
Right. For the neck, we assess for general integrity. It should appear relatively short and thick in a newborn, but we check that it's supple and allows for a good range of motion. Can the baby turn their head side to side? We gently palpate along the neck and clavicles, collarbones. We're feeling for any masses like a swollen lymph node or any lumps or crepitus, a crackling feeling, over the clavicles, which could indicate a clavicular fracture. This is actually one of the most common birth injuries, especially in larger babies or during difficult deliveries, and it usually heals well on its own with careful handling. We also check for any tightness or mass in the sternocleidomastoid muscle, the big muscle running down the side of the neck, which could indicate torticollis or wry neck, causing the head to tilt. Moving to the chest, it should appear symmetrical in shape and movement with breathing. A newborn's chest is somewhat barrel-shaped, meaning the front-to-back diameter is similar to the side-to-side diameter. We look at the breasts. Babies, both boys and girls, should have two symmetrical nipples located appropriately. Occasionally, you might see extra nipples, supernumerary nipples, somewhere along the milk line, running down from the armpit towards the groin. These are usually small, undeveloped, and are generally considered a benign normal variant, but their presence is noted.
Can newborn breasts look swollen?
Yes, interestingly, due to the influence of residual maternal estrogen hormones, both male and female newborns may sometimes have slightly engorged breast tissue right under the nipples in the first week or two. Occasionally, a tiny drop of whitish fluid, which is milk, might even be expressed. This is also a normal temporary finding related to hormone withdrawal and resolves on its own. Parents should be advised not to squeeze the breasts.
Good to know. And the abdomen. What are we checking there? And can you talk about comprehensive umbilical cord care? That's always a big topic for new parents.
The abdomen should appear soft and slightly rounded, not tightly distended or rigid. A distended, tight abdomen could indicate an intestinal obstruction or other serious intra-abdominal issue. Rigidity might suggest peritonitis. We listen with a stethoscope for bowel sounds in all four quadrants. They're usually present within the first hour or two after birth, sounding like clicks and gurgles. We also gently palpate the abdomen to feel for any obvious masses or tenderness. As for the umbilical cord stump, yes, this is definitely a focus for parents. We meticulously assess the stump and the skin around its base. We're looking for any signs of infection, omphalitis, which would include redness spreading onto the abdominal skin, significant foul-smelling drainage, a little bit of yellowish ooze as it dries as normal, or tenderness. We also check for any active bleeding from the vessels. For cleaning, current recommendations usually emphasize keeping the cord stump clean and dry to promote healing and separation. Gentle cleaning with plain warm water and a cotton swab or gauze around the base, only if it gets soiled with urine or stool, is typically sufficient. Using alcohol or other antiseptics is generally no longer recommended as it might delay cord separation. The key is allowing air exposure to help it dry out. Folding the diaper down below the stump is important.
And when does it usually fall off? What about baths?
The stump typically dries up, turns black, and falls off on its own within 1 to 2 weeks, though it can sometimes take up to 3 weeks. It's important to educate parents that sponge baths are recommended until after the umbilical cord stump has completely fallen off and the site is healed. Submerging the stump in bath water before it separates might increase the risk of infection and delay drying. The plastic cord clamp that's applied at birth is usually removed by the nurse after about 24 hours once the stump has started to dry and shrink sufficiently to prevent bleeding. And again, we always confirm the cord has the normal 3 vessels, 2 arteries, 1 vein.
Okay. Dry cord care, sponge baths till it's off. Got it. What about the genitalia for both male and female newborns? What are the key observations for normal development and any potential abnormalities we need to look for?
Sure. For male infants, the scrotum should appear pendulous, hanging down, and have well-developed rugae, which are those characteristic wrinkles or folds on the scrotal sac. The presence of deep rugae is a sign of gestational maturity, especially in a term infant. In preterm boys, the scrotum might be smaller, smoother, and less pendulous. We gently palpate the scrotum to confirm that both tests are descended into the scrotal sac. Sometimes one or both tests might be undescended, cryptorchidism, meaning they're still up in the inguinal canal or abdomen. This is more common in preterm boys. If testes are not descended in a term baby, it is noted, as they may still descend spontaneously within the first few months, but if not, they might require monitoring or later surgical intervention, orchiopexy, to bring them down, as undescended tests carry risks for infertility and cancer later in life.
Yes.
We check the urinary meatus, which is the opening of the urethra. It should be located right at the tip of the glans penis. If the opening is located on the underside, ventral surface of the penis, it's called hypospadias. If it's located on the top side, dorsal surface, it's called epispadias, which is much rarer. Both hypospadias and epispadias are considered congenital abnormalities that will require surgical correction later, usually between 6–18 months of age. Importantly, circumcision is typically contraindicated in babies with hypospadias, as the foreskin might be needed for the surgical repair. And speaking of circumcision, it's an elective surgical procedure to remove the foreskin. It requires thorough parental discussion, education about the potential risks, bleeding, infection, injury, and debated benefits, potential reduction in UTIs, STIs, and signed informed consent before it's performed. Post-circumcision care instructions are also vital.
Okay, lots to check for boys. What about female infants?
For female infants, in a term infant, the labia majora, the outer folds, should be prominent and typically cover the smaller labia minora and the clitoris. This indicates good gestational maturity. In preterm girls, the labia majora may be smaller and separated, making the labia minora and clitoris appear more prominent. Vernix caseosa may still be present between the labial folds, which is normal. As we discussed earlier under GU milestones, pseudomenstruation, that small amount of whitish vaginal discharge, sometimes tinged with blood, is a normal finding in the first week or so due to maternal hormone withdrawal and is temporary. It's important to reassure parents about this. We also check for any ambiguity in the genitalia that might make it difficult to determine the sex, which would require further investigation.
Moving down to the extremities now, arms and legs. What are we looking for in terms of movement and structure? And this raises an important question. How do those fascinating neurological reflexes we check demonstrate the brain and nerve development in a healthy newborn?
In the extremities, we first ensure that all 4 limbs move freely and symmetrically. We watch for spontaneous movement and also gently move the limbs through their range of motion. Asymmetry could suggest a nerve injury, like a brachial plexus injury affecting an arm or a fracture. The arms and legs should generally be held in that flexed posture we talked about. We meticulously check that the baby has 10 fingers and 10 toes. We note any extra digits, polydactyly, or any webbing or fusion of digits, syndactyly. We look at the creases on the palms. A single transverse palmar crease, sometimes called a simian crease, can be normal, but is also more frequently seen in babies with Down syndrome. We check the feet for position. Are they normally aligned, or is there evidence of clubfoot, talipes equinovarus, where the foot is turned inward and downward? We also perform maneuvers like the Ortolani and Bartlett test to check for hip dysplasia or instability. The neurological reflexes are indeed crucial indicators of neurological intactness and development. They demonstrate the functional integrity of the central nervous system, particularly the brainstem and spinal cord pathways. Their presence, strength, and symmetry are key assessment points. Absence or asymmetry of these primitive reflexes can signal neurological problems.
Can you remind us of the main ones you check?
Sure, the common ones include the palmar grasp reflex. When you place your finger in the baby's palm, their fingers will curl around it and grasp it tightly, sometimes surprisingly strong. This signifies an intact neurological pathway for grasping. the plantar grasp. Similar to the palmar grasp, when you place your finger firmly against the base of the baby's toes, the toes will curl downward as if trying to grasp the finger. The Moro reflex, often called the startle reflex, this is a really important one. If you support the baby's head and back and allow the head to gently and suddenly drop back slightly while still fully supported, or if there's a sudden loud noise, the baby should respond symmetrically. They'll throw their arms and legs outward, abduction and extension, open their hands, and then quickly bring their arms back towards the body, adduction and flexion, often followed by a cry. A symmetrical Moro response indicates intact neurological function. Absence or asymmetry, one side not responding, can indicate a central nervous system problem or a peripheral injury like a fractured clavicle or brachial plexus injury on the non-responding side.
Wow, so that little reflex tells you a lot. What else?
The Babinski reflex. When you firmly stroke the sole of the foot along the outer edge from the heel up towards the toes, the baby's toe should fan outward, hyperextend, and the big toe should dorsiflex, point upward. This is actually an abnormal response in adults where the toe should curl downward. But in newborns and infants up to about 1 year, this fanning response, a positive Babinski, is normal and indicates immature corticospinal tract development. And the rooting reflex, which we often assess along with the sucking reflex when checking the face and mouth, but it's vital for feeding. If you gently stroke the baby's cheek near the corner of the mouth, they should turn their head towards that stimulus and open their mouth, actively searching for a nipple. This helps them find the food source. There are others too, like the stepping reflex, but the presence, strength, and importantly, the symmetry of these primitive reflexes provide a really good window into the health of the newborn's developing nervous system.
That's fascinating how those seemingly simple reactions tell such a complex story.
Yeah.
And finally, a thorough assessment includes looking at the baby's back. What are we specifically looking for there?
Turning the baby over carefully to examine the back is essential. We thoroughly assess the skin again, looking for any birthmarks, like Mongolian spots that may not have been visible from the front. We carefully palpate and visually inspect the entire length of the spine. It should appear straight and feel intact without any obvious gaps, curves, scoliosis, or defects. We also ensure rectal patency by visually checking that the anus is present, open, and in the normal position. Sometimes temperature is taken rectally initially, which confirms patency, but visual inspection is key. We also note the passage of meconium, which confirms patency from the inside out. We pay close attention to the base of the spine in the sacral area, right above the buttocks crease. We look for a sacral dimple. A simple, shallow dimple located low down within the gluteal crease is very common and usually completely normal. However, certain features raise concern for an underlying spinal cord abnormality, like spina bifida occulta, a hidden spinal defect. These concerning features would be a very deep dimple, a dimple located above the gluteal crease, a dimple associated with a tuft of hair growing out of it, a fatty lump, lipoma, a skin tag, or a patch of discolored skin in that area. Any of these findings would warrant further investigation, usually starting with an ultrasound of the spine, to rule out tethered cord or other neural tube defects.
We've thoroughly examined the physical aspects and those crucial early adaptations. But there are also hidden health clues unearthed through routine lab work performed on newborns. Let's talk about decoding some of those crucial lab insights that really complete the picture of a newborn's health status. What are we looking for specifically with blood type and Rh factor, and why is knowing this information so critical right from the start?
Identifying the baby's blood type, A, B, or O, and their Rh factor, positive or negative, usually from cord blood collected at delivery, is absolutely critical, especially in relation to the mother's blood type and Rh status. This is primarily important for detecting potential ABO or Rh incompatibilities between the mother and the baby. For example, if the mother is Rh negative and the baby is Rh positive, the mother's immune system could have produced antibodies against the baby's Rh positive red blood cells during pregnancy or delivery. These antibodies can cross the placenta and attack the baby's red blood cells, causing hemolytic disease of the newborn, HDN. This can lead to severe anemia and jaundice in the baby. Knowing the Rh status allows us to anticipate this risk and administer RhoDGAM, Rh immunoglobulin, to the Rh negative mother after delivery and sometimes during pregnancy to prevent her from forming these antibodies in future pregnancies.
And ABO incompatibility.
Similarly, ABO incompatibility can occur most commonly if the mother is blood type O and the baby is type A or type B. Mom's naturally occurring anti-A or anti-B antibodies can cross the placenta and cause a milder form of red blood cell breakdown and jaundice in the baby. So, knowing both mom's and baby's blood types helps us anticipate and monitor for exaggerated jaundice, even if it's just ABO incompatibility, which is usually less severe than Rh disease but still needs watching.
Okay, so blood type is key for jaundice risk. What about the complete blood count, CBC? What are the normal ranges for hemoglobin and other hematology values in a newborn, and are there any important nuances compared to adult values?
Right, for hematology, newborn values are quite different from adults, reflecting the unique physiology of this transition period. Normal ranges are generally higher. Hemoglobin, HDB, is typically quite high, between 14 and 24 GDL. Hematocrit, HCT, the percentage of blood volume made up of red cells, is also high, usually between 44% and 64%. Red blood cell count, RBCs, is correspondingly high, around 4.8 to 7.1 million cells per cubic millimeter. This polycythemia, or high red cell count, is normal at birth and reflects the lower oxygen environment in utero. These levels then gradually decrease over the first few months. Now, what's particularly insightful and sometimes confusing is the white blood cell count, WBCs. The normal range in a newborn is quite wide and high, typically 9,000 to 30,000 cells per cubic millimeter in the first 24 hours.
30,000. That sounds really high, like an infection in an adult.
Exactly, and that's the nuance. An elevated WBC count in the first 24 hours can actually be a completely normal finding in a newborn. It often reflects the physiological stress of labor and the adaptation process itself, rather than necessarily indicating an infection. The stress of birth can cause a release of stored white cells. However, after that first 24-hour mark, if the WBC count remains significantly elevated, or especially if it's very low, leukopenia, or if there's a significant shift in the types of white blood cells, like many immature forms, then we would become much more concerned about the possibility of sepsis infection and would investigate further with blood cultures and other tests. So context and timing are key for interpreting WBCs.
That's a really crucial distinction for interpretation. What about glucose levels? When are those typically checked? What's considered the normal range for a newborn? And what are the risks associated with low blood sugar or hypoglycemia?
Normal blood glucose for a term newborn is generally considered to be between 40 and 60 milligdl in the first few hours, and ideally above 45 milligdl after the initial 4 hours of life. Some guidelines aim for consistently above 50 milligdl after the first day. Glucose levels aren't routinely checked on every healthy term baby, but screening is definitely indicated if the baby is considered at risk for hypoglycemia. This includes babies who are experiencing cold stress, because maintaining temperature burns glucose rapidly. Babies born to diabetic mothers, maternal hyperglycemia leads to fetal hyperinsulinism, which causes rapid glucose drop after the cord is cut. Babies who are small for gestational age, SGA, or large for gestational age, LGA, due to issues with reserves or insulin, or babies who are preterm due to immature metabolic systems and low glycogen stores. Infants showing symptoms like jitteriness, lethargy, or poor feeding would also be checked immediately. For these high-risk infants, glucose levels are often monitored frequently, usually before feeds, for the first 12-24 hours or longer until stable.
Okay, so if a baby's glucose is found to be low, what's the immediate most effective course of action to take?
If hypoglycemia is suspected based on symptoms or confirmed by a screening test, often a heel stick with a glucometer, the signs would typically be jitteriness or tremors, lethargy or floppiness, poor feeding or weak cry, sometimes even apnea or seizures in severe cases. The first and often most effective action to take, if the glucose is low but the baby is asymptomatic or only mildly symptomatic, for example 25-30 milligdl, is to feed the baby immediately. Providing breast milk or formula delivers natural glucose and calories. Skin-to-skin contact can also help stabilize glucose. Then, we recheck the glucose level about 30-60 minutes after the feed to confirm it has risen adequately. If it's still low, or if the baby was significantly symptomatic or had a very low initial reading, example 25 milligdl, then oral glucose gel, a 40% dextrose gel rubbed into the inside of the cheek, may be given, followed by feeding. This provides a rapid source of glucose. In severe or persistent cases, intravenous IV dextrose infusion might be necessary. Rapid intervention is absolutely key because prolonged or severe hypoglycemia can potentially cause neurological injury.
Feed first, then reassess. Makes sense. Finally, bilirubin levels. We talked about physiological jaundice earlier being common. How are bilirubin levels accurately tracked in newborns, and what's the typical expected progression?
Bilirubin levels are usually screened non-invasively using a transcutaneous bilirubinometer, TCB. This is a handheld device that's gently pressed against the baby's forehead or sternum. It measures the yellowness of the subcutaneous tissue and provides an estimated bilirubin level almost instantly. It's a great screening tool because it avoids frequent heel sticks. If the TCB level is elevated according to age-specific nomograms, charts that show normal ranges based on hours of life, or if significant jaundice is noted clinically, then a total serum bilirubin TSB level is typically drawn via a heel stick blood test for confirmation and more precise measurement. The normal progression of bilirubin in a healthy term newborn, reflecting that physiological process of red cell breakdown and immature liver conjugation, typically follows a pattern. It might be around 2 to 6 milligdl at 24 hours of life, rising to perhaps 6 to 7 milligdl at 48 hours, often peaking somewhere between 72 and 96 hours, 3 to 4 days, maybe reaching 10, 12 milligdl or slightly higher, and then gradually tapering off over the next week or two. These levels correlate with the normal physiological jaundice we often see. We monitor these levels closely, plotting them on the age-specific nomograms, because excessively high levels, hyperbilirubinemia, or rapidly rising levels can be dangerous. If bilirubin levels get too high, the unconjugated bilirubin can cross the blood-brain barrier and deposit in the brain tissue, leading to kernicterus, acute bilirubin encephalopathy, a serious condition causing permanent neurological damage, hearing loss, and movement disorders. So screening and timely treatment, usually phototherapy, if levels get too high, are critical.
With all this assessment and lab work in mind, let's pivot to some crucial care practices and essential parent teaching that happens before discharge. This raises an important question. Why are some of these preventative medications, like the vitamin K shot, considered vital for nearly every newborn? And what options do parents have regarding them?
Right. These routine preventative measures are considered vital because newborns are born with certain physiological vulnerabilities that these interventions directly address. The vitamin K shot, phytonadione, is administered as an intramuscular injection, usually into the thigh muscle shortly after birth. Its purpose is to help the baby's blood clot properly. Newborns are born with very low levels of vitamin K because it doesn't cross the placenta well, and their gut is sterile initially, meaning that they don't have the bacteria needed to synthesize their own vitamin K right away. This temporary deficiency puts them at risk for vitamin K deficiency bleeding, VKDB, formerly known as hemorrhagic disease of the newborn. This is a rare but potentially catastrophic bleeding disorder that can cause bleeding anywhere, including into the brain. The vitamin K shot provides immediate protection against VKDB.
Can parents refuse it?
Yes, parents do have the right to refuse the vitamin K shot, but it's absolutely essential that they receive thorough education about the significant, potentially life-threatening risks of VKDB if they choose to decline. While VKDB is rare overall, it's almost entirely preventable with the shot. Oral vitamin K regimens exist, but are generally considered less effective and require multiple doses. The hepatitis B vaccine is another crucial preventative measure recommended for all newborns. The first dose of the 3-dose series is typically given within 24 hours of birth, again with parental consent. This protects the baby against hepatitis B virus infection, a serious liver disease. It's given at birth because hepatitis B can be transmitted from an infected mother to her baby during delivery, even if the mother doesn't know she's infected, as many infections are asymptomatic. Vaccinating at birth provides early protection. If the mother is known to be hepatitis B positive, the baby receives both the vaccine and hepatitis B immune globulin, HBIG, within 12 hours for maximum protection.
Okay, vitamin K for clotting, Hep B for liver protection. What about the eye ointment?
And then there's the prophylactic eye ointment, typically erythromycin ophthalmic ointment, though tetracycline or others might be used. A thin ribbon of this antibiotic ointment is applied into the lower conjunctival sac of each eye, usually within an hour or two after birth. The purpose of this is to prevent ophthalmia neonatorum, which is conjunctivitis eye infection in the newborn occurring within the first month. Specifically, it's highly effective at preventing conjunctivitis caused by Neisseria gonorrhea, which can be acquired during passage through the birth canal if the mother has gonorrhea. Gonococcal ophthalmia can rapidly lead to corneal ulceration and blindness if untreated. While less effective against chlamydial conjunctivitis, which is more common, erythromycin is still the standard preventative measure. Again, this requires parental consent after explanation. Some parents decline due to concerns about temporary eye irritation or interference with bonding, but they need to understand the risks, especially if maternal STI screening wasn't done or results are unknown.
Beyond medications, what about supporting new parents with breastfeeding? That seems so crucial, especially in those critical first hours and days.
Oh, breastfeeding support is absolutely crucial for successful initiation and long-term establishment, if that's the parent's choice. Getting off to a good start makes a huge difference. Immediate skin-to-skin contact right after birth, assuming the baby is stable, is incredibly beneficial. It helps regulate the baby's temperature and breathing, stabilizes their blood sugar, promotes bonding, and importantly, it triggers the baby's natural rooting and sucking reflexes, often leading to the first latch within that first golden hour. It's ideal to encourage that first latch attempt within the first hour or two of life during the baby's initial quiet alert state before they typically fall into a deep birthday nap, a period of relative inactivity lasting several hours where they can be much harder to wake and less interested in feeding.
What kind of help is available?
Lactation consultants, IVCLCs, are invaluable resources for new parents. They can provide hands-on guidance with positioning the baby correctly, achieving a proper deep latch, which shouldn't be painful for the mother, identifying feeding cues, and troubleshooting common challenges like sore nipples or concerns about milk supply. Nurses also play a huge role in providing support and assessment. We assess the effectiveness of feeding by looking for signs of a good latch, baby's mouth wide open, lips flanged out, more areola visible above the top lip than below. Listening for audible swallowing, not just sucking. Observing the baby's output, wet and dirty diapers, and checking the mother's comfort. Feeding shouldn't hurt after the initial latch on. Nurses might even use a standardized latch score tool like the LATCH score to document and assess feeding effectiveness objectively. It's also important to always discuss with parents their preference regarding pacifier use. While pacifiers can have benefits later on, like potentially reducing SIDS risk during sleep, early introduction, especially in the first few weeks before breastfeeding is well established, can sometimes interfere with learning to latch effectively or might mask early feeding cues. So delaying pacifier use until breastfeeding is going well is often recommended.
With parents preparing to take their newborn home, what does all this assessment and care mean for ensuring safety, particularly regarding those vital safe sleep practices? This seems like such a critical piece of education.
Safe sleep practices are absolutely paramount for preventing sudden infant death syndrome, SIDs, and other sleep-related infant deaths, like accidental suffocation or strangulation in bed. It's one of the most important safety messages we give parents before discharge. We teach every parent the ABCs of safe sleep. The baby should sleep alone, on their back, in a safe crib, or bassinet or pack and play. Alone means absolutely nothing else should be in the sleep space with the baby. No pillows, no blankets, use a sleep sack instead, no stuffed animals, no bumper pads, which are now widely discouraged due to suffocation and entrapment risks, no positioning devices. The sleep surface should be firm and flat with only a tight-fitting sheet. Back means babies should always be placed to sleep flat on their backs for every sleep naps and nighttime until they reach at least 1 year of age. Once a baby can consistently roll from back to stomach and stomach to back on their own, you don't have to keep flipping them back over if they roll onto their tummy during sleep, but you should still always place them on their back initially. Sleeping on the back significantly reduces the risk of SIDS. And in a crib or other safety-approved sleep surface means the baby should have their own separate sleep space. Room sharing, having the baby's crib in the parent's room, is recommended for at least the first 6 months, ideally the first year, as it reduces SID's risk. However, bed sharing, having the baby sleep in the parent's bed, is strongly discouraged due to significant risks of suffocation, entrapment, and overlay, especially if parents smoke, are overly tired, or have consumed alcohol or medications.
ABCs, alone, back crib, simple but so important. And finally, bathing practices. We touched on delayed bathing earlier for temperature stability, but what's the full guidance for parents on bathing their newborn once they get home?
Yes, as we discussed, the initial bath is typically delayed for at least 8-24 hours after birth to allow for thermoregulation, skin-to-skin bonding, and to let that beneficial vernix provide its protection. For home care, the guidance is clear. Parents are taught that sponge baths are recommended only until the umbilical cord stump has completely fallen off, usually 1 to 2 weeks, and D, if the baby was circumcised, for boys, until the circumcision site has fully healed, which also typically takes 1 to 2 weeks. Giving only sponge baths during that time helps prevent infection and keeps these sensitive areas dry, promoting healing. Once the cord stump is off and the circumcision, if applicable, is healed, then immersion baths, tub baths, can begin. For the home environment regarding bathing and warmth, parents should be educated to always check the bath water temperature carefully. It should feel warm, not hot, on their wrist or elbow, around 100 degrees arid or 37-38 degrees wet. The room should be kept warm during and after the bath to prevent chilling. They should have everything ready beforehand so the bath is quick. And afterwards, pat the baby dry thoroughly, especially in the creases. Dress them appropriately, remembering that general rule of 1 more layer than an adult might wear, and maybe put a hat on if the house is cool. Preventing heat loss remains important even at home. #outro.
Wow, what an incredible journey we've taken today, really diving deep into the world of the newborn. We've navigated through the truly astounding physiological adaptations a newborn makes in those first moments, hours, and days after leaving the womb. We explored the meticulous head-to-toe examination that uncovers their health status piece by piece. And we illuminated the crucial lab work and preventative care that work together to ensure a healthy start.
Yeah, from the rapid insights we get from the APGAR score to the hidden power of that amazing brown fat and the delicate balance involved in closing those fetal shunts. Not to mention the intricate dance of neonatal reflexes. It's just abundantly clear that a newborn's first days are nothing short of miraculous, physiologically speaking.
And understanding these intricate details, hopefully for you listening, equips you not just with knowledge, but with a profound appreciation for the incredible design of the human body and the dedicated, nuanced care that surrounds the very beginning of life. This knowledge empowers you, whether you're a parent, caregiver, or student, to confidently observe, understand, and even advocate for the incredible transitions happening in those early days.
Absolutely. And if we connect this to the bigger picture, the theme of adaptability, just consider how these initial, really dramatic physiological switches, this incredible biological resilience that's built into our earliest moments, how they fundamentally prepare us for a lifetime of coping with and adapting to environmental changes. It's like a foundational lesson in survival and adaptation, coded deep within our biology right from the start.
That's a great point. It makes you wonder, doesn't it? What other critical yet often unseen biological transitions occur throughout our lives that we similarly just take for granted? From the hormonal shifts of puberty to the gradual changes of aging.
Exactly. How might a deeper understanding of our fundamental physiological resilience, really forged in those first breaths and those first battles against the cold, change our perspective on health, development, and even our potential at every single stage of the human experience? It really makes you wonder about the ongoing, quiet marvels happening within us all the time, doesn't it?